Hi, and thank you for listening today. The Pancreatic Cancer 2022 Summit Patient and Carer Group wanted to be involved at this event because we all have one thing in common. We all want to help future patients and their loved ones have a better experience of care in health services and be supported by you to fully explore all their treatment options. Hi, I'm Rita. I was diagnosed 4 years ago. I was initially told that I had 5 months to live. I'm now on palliative chemotherapy. What has worked in my favor is a positive attitude and always remaining cheerful.
Hi, I'm Cherie and I'm a carer for my husband who was diagnosed with stage 4 pancreatic adenocarcinoma in September of 2020.
Cherie and I will be talking to you about the 3 main themes from our patient and carers group survey and discussion. A positive that was commented on was the excellence of some individual clinicians' communication. We also found additional help from services such as palliative care and from organizations like PanCare Foundation to be invaluable. But also, when looking at our qualitative experiences, we think there is a lot of opportunity to make life easier for us. These 3 themes are 1. Patient advocacy, 2. The importance of hope, and 3. Supportive care. I'm talking to you about our first theme of patient advocacy.
And I'll be talking to you about our second theme, which we feel most passionately about, and that is the importance of hope. Rita and I will then finish with how we think supportive care can be improved.
Theme 1, patient advocacy. It's very important to have an advocate at appointments from time of diagnosis. Advocacy needs to be available to patients straight away and can dramatically improve our care. It takes courage to challenge and to ask questions about other options. Patients can't always do this themselves, so they need an advocate. Side effects can be vague, so it's hard for patients to remember when they go to appointments. It's easier when someone else is there to remind us about issues that have arisen. Patients' mental clarity and memory is also affected by disease and treatments. So we need an advocate as a second external brain. Note-taking and recording, which advocates can help with. Information would sometimes change from appointment to appointment, and it's important to get the right information. Note-taking helps with this.
Our second theme of the importance of hope is the one closest to our hearts. The hopelessness and helplessness we experience when a clinician first communicates to us that we or our loved ones have a terminal diagnosis is unforgettable. And what immediately follows makes it worse, a feeling that there is no in-depth discussion of what the treatment options for pancreatic cancer are. We understand that this is because in the minds of many doctors, there aren't any. Palliative chemo is the only option for stage 4. Many of us left appointments without a sense of where to go next, who to ask, or even what to ask. Pancreatic cancer has low health literacy, so the average patient and carer has no knowledge base on which to build. It's a case of you don't know what you don't know. We might seem content with your explanation at appointments, but it's more likely we are silent because we simply don't know what questions we should have for you. And the prognosis you have just given us means we are completely overwhelmed. Because we don't know what we don't know, it's important for us to get help from a clinician with pancreatic cancer expertise. Pancreatic cancer is relatively uncommon, and it's really beneficial for clinicians to have that deeper level of understanding of the disease. For my husband and myself, our initial clinician said our only option was palliative chemo. We went along with that treatment plan, but my husband has now just had his second operation to remove his last tumours. While his first operation was emergency surgery, it was only possible because the chemo had been effective for him, but we weren't even aware of this until after his surgery. If he hadn't have had internal bleeding, I'm not sure if he would ever have been offered surgery. When looking at his second surgery, I discovered that radiation was also an option. I only discovered this when I sought a second opinion due to the encouragement of an international pancreatic cancer group. A lot of us use the same expressions to describe what we had been through, such as, "If I had known then what I know now," or "With hindsight I can see," or "It wasn't until people in my patient support group told me." However, the reality behind these phrases is that a lot of us experienced an incredibly high burden of self-directed research, a lot of it undertaken online, and not all of it accurate or applicable to us. But in the absence of clinician explanations of chemotherapy, radiotherapy, surgery, and clinical trial options that are specifically tailored to our individual situations, we are always going to seek out hope elsewhere. Because given the dire prognosis we've been delivered, what have you got to lose? To summarise the importance of communicating hope, we found if you're not given any hope, it's easy to become overwhelmed with negativity that then leaves you feeling helpless and unable to advocate for yourself or your loved one. Even if the prognosis leaves little hope, there are ways to improve your quality of life, but you are not likely to even explore these if you believe your outcome is predetermined. A wise oncologist once said to me, "I don't have a crystal ball. I can't tell you what the outcome's going to be." Clinicians are not always pancreatic cancer specialists. Depending on where you are treated, your case may not even be looked at by a multidisciplinary team. The only review of your particular situation is by the person your GP referred you to. Treatment options are not always presented or fully discussed. Second opinions are not always offered. It's only when we undertake research ourselves that we find out about different treatments. And by talking to other carers, do we become aware of other options, not just for treatment, but to improve quality of life. However, not all consumers are in a position to do this research. The burden of research on consumers is too high, and we need help from health services or support services with this. Personally, I know so much of my husband's experience has been driven by me. I had to reach out, explore, and connect with experts and research. It was relentless, and I don't think many people would have the capacity to do what I've done. This needs to change. Genomic profiling and clinical trials are hugely important for advanced stage and terminal diagnoses. We are here, we are ready and willing, and a lot of us want to go into clinical trials. Pancreatic cancer patients don't have time to wait. We need fast-track trials so patients can participate while they're still here. We also need to coordinate biopsies and surgeries to remove sufficient tissue samples for genomic profiling at the time of diagnosis. This should be standard practice. Funding for this is also an issue. It is hugely expensive. Getting a genomic profile of your tumour early can allow more options for treatment if you have relevant mutations and to join upcoming clinical trials. Rita and I will now finish with how we think supportive care can be improved.
Theme 3, Supportive Care. A pancreatic upper GI cancer specialist nurse to assist as a single point of contact would be so useful. We have them for breast cancer, why not upper GI? Information on supportive care at the time of diagnosis. Some patients reported finding out way too late. Only 20% of patients in our survey recalled doing a supportive care screen. What can be done to help clinicians refer patients for support? Access to social workers who know about services available, including financial counseling. Carers need support as well. A lot of support offered to patients isn't automatically offered to carers, and that needs to change. As a surgeon said, my husband didn't have cancer. My husband and I had cancer. My husband was going to have to deal with it, and so was I.
It's almost universal that patients and carers have the same response to the word palliative, and that is one of fear. People affected by pancreatic cancer are no different. Hearing the word palliative, especially at your first appointment with a clinician, is so confronting. Not only have you just been told that you have a terminal illness, But when you are told chemo will be palliative, it makes you think you are immediately at the end of your life. We need to change either the terminology or our understanding of the word.
To summarize our recommendations: 1. Access to advocacy at the time of diagnosis and note-taking during appointments. 2. The importance of hope when communicating prognosis. 3. Thorough discussion of treatment available that includes why some options may not be appropriate and supporting second opinions. 4. Sufficient tissue sample size and early accessible and affordable profiling. 5. Early referrals to supportive care and a focus on offering support for carers. 6. Explanation of palliative care with sensitivity and its value in symptom management. Thank you for listening. So many of the clinicians we have come into contact with are wonderfully dedicated to help us, and your attendance here today confirms this. We look forward to hearing your ideas of improving our cancer care.